Welcome to AETCM, the emergency medicine channel. Yes, we are moving on the next system in our Nancy Caroli, that is gastrointestinal emergency. So as usual, first thing we are going to discuss regarding the gastrointestinal assessment point, more specifically in a pre-hospital region. So it is the format we are well familiar regarding this one. So again we have to start up with the scene size of primary survey history taking, secondary assessment, and then finally reassessment. So if you are concentrating on pre-hospital oriented means, so before transporting a person from the scene, so we have to do these two things. So scene size up and then primary survey. So and then coming while transit or during transport, you have to take about the history taking and then secondary assessment. So reassessment should be every 5 minutes if it is unstable case, or stable case means every 15 minutes we have to reassess the case. So this is regarding the patient assessment format. So what are the things we have to look for the scene size up? So again this is same thing. So before the getting into the scene, we have to verify whether the scene is safety or not, whether we need any additional resources like fire support or police force. So those are the additional support is that we need or not. Third thing, number of patients. So whether that whatever we have a resources that is adequate or not, either we need a more resources for that a number of patients we are assessing, and then mechanism of injury or nature of illness. Mainly in GA emergency, that is nature of illness. We are discussing regarding the medical emergency, right? So nature of illness, how the person's, what is the nature of the illness, and then most important thing is a personal protective equipment. So in the focus of gastrointestinal emergency, we may expose something like a body substance, that might be a vomit or diarrhea or some other body substance we may expose, right? So for that reason, here everywhere that is mandatory, more specifically in GA emergency, we are focusing. So coming into primary survey, first we have to form a general impression by seeing the position of the person and then clue from the environment. More important thing is in GA emergency, order is one of the important thing. So in general impression, otherwise we known as the initial 10-second assessment, right? So here we can see the position of the person and then clue from the environment. Order, why, how order is placing major important crucial role means, so if the person is prolonged, he have episodes of long or frequent episode of vomiting or diarrhea means, that foul smelling we can get, right? That is one of the key factor that can help for us. Other thing, so if the person have a extreme bowel obstruction, there we can get a breath smell of stool related things. So that is one of the other key factor we can get it in the order or initial general impression. So and then we are moving on to the mental status assessment. There is a AVPU scale, that's again already we discussed. And then moving on to the steps. Third step, that is a ABCDE, airway, breathing, circulation, disability, exposure. So the GA condition, how it is affecting airway means, so here in that gastrointestinal emergency, regarding the airway patterns, in some medical condition that will be in a questionable state only. Airway patterns in a questionable state, like any other upper gastrointestinal bleed, or if the person have a prolonged vomiting, because of that the person may get dehydrated and dehydrated drowsy state. If you are progressing means, that also there also the airway patency will be in a questionable mark. So in this condition, we have to think about appropriate step of management we have to take care, like intervention. If you are suspecting any upper GI bleed means, proper drainage. Proper drainage in the sense, we'll do how we will manage. Initially we have to position the person, like left lateral position we have to do, and then proper suctioning we have to take care, oral suctioning or any nasogastric tube decompression needed means, that also we can go for. This is regarding the airway. Coming into breathing, so breathing majorly in the GA emergency, because of GA emergency it won't directly put hand on the breathing, but if you suspected any breathing difficulty or if you suspecting any crackle sound while auscultation means that will be because of the any aspiration. So that is one of the major important complication in the GA emergency. If the person have any upper GI bleed, because of that, so we told because of drowsy the person may get aspirate. So on that time that will directly affect the breathing. Apart from this, because of GA emergency, it won't affect the breathing part. So it's like we told aspiration. If the person have any respiratory distress means that is a what I want to tell more complicating one that may complicate the case. So that is one of the thing. In this case, intervention rate you have to administer the high concentration of oxygen and then prevent aspiration. How we can prevent the aspiration? Then same thing only. So if the person have any upper GI bleed means we have to do the proper drainage, the positioning of the person, and then we have to do the suctioning, frequent suctioning. And then moreover, while administering oxygen, some person they may have a feeling of nausea and vomiting with that oxygen mask itself. Because of that material, because of the material smell, they may have that material itself that will provoke the vomiting. So in that case, what we can do means we can go by the blow by technique. So we know that in a pediatric cases and all, without any mask, we will attach the tubing alone. No? With that tubing alone, we will give the oxygen. That is called blow by technique. So that can we can use, and then auscultate the lung sounds. So that will give auscultating the lung sound will give the idea regarding the any aspiration related things. So we can hear the crepitation sound in the base of the lung. So this is one of the key factor we can go for. Circulation wise, again we have to assess the color, temperature, moisture, pulse rate, peripheral pulse, central pulse. So here we should not check like whether the pulse is there or not, pulse is present or not. That is a one factor. Mean the same time we have to check the quality of the pulse is most important, and then rhythm of the pulse is most important. So these are the some additional factor also we have to think. So we should not think like pulse, whether the pulse is present or not. That is even with the non-medical people also they can, if you are talking about or if you are told about those are things also, they can easily assess the status whether that is present or not. So being a medical professional or being a EMT, we should know whether the pulse is bounding pulse or whether the pulse is weak pulse. So these are the some key factors that will help us to determine whether the person in a dehydration or hypovolemia. So those are the factors that will give clue, right? That is why we have to check the whether the pulse quality and then rhythm of the pulse, those are color of the skin, whether it is a cyanosed or pink or mottled skin. So everything we have to check for. And then other important thing here, you can add SpO2. So there is one of the factor that will helps to understand the peripheral oxygenation, right? So this factor also we can use. But in SpO2 wise, majority of our people will misdirect because of the SpO2. How we are misdirecting means, so and keep in mind SpO2 will assess the status of peripheral oxygenation, right? It won't assess the number of hemoglobin that is present in our blood. Means it will only assess the oxygenation. I give one scenario. So if you are handling like one case with any bleeding, like external or internal bleeding cases, so active bleeding cases, so there you are keeping the SpO2 probe. It is the SpO2 probe, it is showing 98% on the room air. So the person in room air, the SpO2 is showing 98. So here the person have a active bleeding. So you can remember a external bleeding. So this is most visible only. The person have a active visible bleeding, but here the SpO2 is 98%. What the factor, what I want to tell, what I want to impose here is that here the SpO2 means it is a status of oxygenation, not about the level of hemoglobin in your blood. So it will assess only the oxygenation status. Means why we are telling means because of this 98% majority of our people will think so the person not be in a distress, so we don't want any intervention. Think, so here the active bleeding means normal hemoglobin level if it is about 12 to 14, right? So you can think about 12 grams per deciliter. Because of the bleeding, what will happen, hemoglobin deficit will be there. So the carrier who is carrying that oxygen, that carrier level will reduce. So the person may have a 6 gram per deciliter only in her blood, in his or her blood. So in that 6 gram, how many percentage of the hemoglobin carried that oxygen? That is called the SpO2, right? So if you are getting the SpO2, in that 6 gram, 98 percentage of the hemoglobin carried oxygen. That is the reading only we are getting. Not, we are not getting the reading of 6 grams. So not, we are not getting the reading of how many carriers we have in our blood. So what at final what we are telling means, because of SpO2 we should not think the person is not in a distress. SpO2 only for the oxygenation status. So the one important thing. Other thing, SpO2 sometimes that also mismatch will be there. If the person have a carbon monoxide poisoning also, there will be a mismatch. Anyway, there is a one reliable factor in the oxygenation status. Still, we can rely on that, but the pitfalls also there, whether because of the carbon monoxide poisoning, because of the active bleeding case also we can misdirect. Just to keep in mind, anyway we have to go for the next thing. And then disability exposure also we have to manage. So coming into next part, that is our history taking. For history taking we are using the sample history, right? Signs and symptoms, allergy, medication, past medical history, last oral intake, and then even leading to illness. So in majority of the GI condition, that is a long standing one, means there is a chronic condition. So while taking an history we have to thoroughly go through the past medical history and past surgical history. If they are on any active medications, if they are inactive any medications, that and all we have to properly go through, then only we have to proceed that some general impression we can form. And then coming into other thing, so it's important that you and your patient have a common frame of reference. So here so you and your while assessing we should be in a common frame, or we should be in a common way of talking should be there. Means here we give an example, one person's diarrhea is another person's soft stool. So regarding bowel history we given, the one person that may have a diarrhea, but other person it will be like a soft stool. In other example we can see one person have a bowel history of 3 times per day, the other person have a bowel history of 1 time per day. So these are the, that is why while taking a history we have to take a proper history. So that is one important thing. And then we have to ask regarding the, we should not forget about the weight, whether the weight is loss or weight gain. And then bowel history as like we told, and then we have to ask regarding the body substance. So either that is vomiting or diarrhea. While collecting these are the substance related history, we have to ask about the quantity, means, or if it is a stool means how many episodes, 2 episodes or 3 episodes. Mean the same time if the vomiting also, how many episodes of vomiting. The second important thing, first thing episodes, second thing what is the content of the substance. It may be a, if it is a vomiting means it may be a food content, or it may be a bilious bile content. So it may, bile content mean it will be like a yellow greenish color. So while taking a substance related history, these two things most important. First one episode, second one content of the substance, third one if any associated symptom is there or not. If you are considering a vomiting means nausea, whether the nausea present or not. And then if you are considering stool diarrhea related history means if any like we can tell like before an diarrhea they may have any constipation related history is there or not. Because of constipation they may take some medication, that medication induced diarrhea. So those are the things that we have to keep in mind. And then regarding bowel history, the content of the bowel we told, right? Content in a stool, it may be like a blood mixed one. So we can tell a term like a melena. Melena means black tarry stool. So mostly it will be because of the upper GI bleed. So upcoming presentation we are going to discuss that, we'll see. Other content like hematoxesia. Hematoxesia means that will be a oozing blood in the anal cavity. There is a fresh frank blood, that will oozing blood, that mainly occur in the anal fissures and then external hemorrhoid cases. Anyway, in upcoming presentation we are going to see, but for content related I am telling. Okay, so these are the things we have to assess. And then coming into any inspection wise, we have to check for the any trauma or past surgery markings or any scars is there or not, and then if any skin irregularities, and then notice any stretch mark, also it's called the stray. So in that image we can see there is a vertical line, right? This vertical line is called stray or stretch marks. So mainly this will occur rapid in acute state if the person is gaining weight or losing weight, means that stray will occur or stretch marks will occur. Okay, in the case of, for example, pregnancy cases, if the person have any severe abdominal edema, ascites cases, if you are reducing, means that will cause the this dry or stretch marks. So any abdominal asymmetrical nature because of tumors, hernia, organomegaly, pregnancy, other masses, tumors, that may cause the abnormal asymmetrical. This is also we have to check in the inspection part. So next is the appearance of the stomach, whether that is a flat abdomen or distended abdomen or concave or a scaphoid abdomen. So in that image we can see flat, scaphoid and then distended abdomen. Distension means if it is a diffuse distension, means then we can know as that is because of the ascites. So if you are notifying any localized area distension, means that is because of any organomegaly. And then next point, without any auscultation with a stethoscope, we can hear the stomach growling sound. That is called the boborygmus. Boborygmus. So here R silent, boborygmus or boborygmi. It can be a normal or it can present with a diarrhea. So there is also we may experience, right, lot of time we can hear our bowel sound without an auscultation, that is called the boborygmus. So coming into first part, that is a inspection. Second part here is a auscultation. So here then what we are going to auscultate means bowel sounds. So the normal bowel sounds, it will be like a 5 to 30 times per minute, that is a normal thing. So it is the nature of the sound will be like a gargling sound, soft gargle sound, and then clicks, that is 5 to 30 per minute. If it is a boboric mess, so means increased hyperperistalsis cases, so we told that will mainly occur in the normal cases also, because of the diarrhea also it can occur. Here the nature of the sound like a loud gargle sound, often heard without a stethoscope. So it may be a greater than 30 per minutes. Okay, and then decreased sounds because of hypoperistalsis, mainly it can indicate the impending intestinal obstruction. Impending means about to happen, so that may lead to the intestinal obstruction. And then here the sound nature will be quiet sound, that will occur less than one sound per 15 to 20 seconds. Less than one means that may be absent, zero or one sound within 15 to 20 seconds. So absent means because of the any bowel obstruction or intestinal paralysis that can occur. Here the sound will be for 2 minutes, there won't be any sound. For 2 minutes you have to auscultate continuous 2 minutes. If you are not hearing any bowel sound, means that is called the absent bowel sounds. So auscultation wise, here we have a four quadrant, right? Right upper, left upper, right lower, left lower. So mainly we can place the four quadrant. We can each side we can auscultate the sound, and then we can come for the conclusion whether that is increased or hypo or absent. Then coming into percussion part, so clearly watch. So first we deal about the inspection. Second we go into the auscultation. Third we are coming into percussion. Fourth we are going into the palpation. So but our other system how we are following means inspection, palpation, percussion, auscultation will be come in the last part. But for its GI system wise, gastrointestinal system, the auscultation will part come into the second place. Why means if you are doing percussion, palpation, mean that will disturb your bowel sound, that will disturb your reading. That is why we are keeping auscultation in a second part. Okay, that is one of the thing we have to keep in mind, and then assessment also we have to go for. Percussion wise, it can reveal the information about its content. So how, whether that is a fluid content or whether that is air content, that is a thing, it will help for us while doing a percussion. So the technique already we know. So if it is a empty stomach or filled with the gas means there we can get a tympanic. If it is a dull sound, majorly in a normal right upper and then left upper quadrant, we can feel the dull sound because of the solid organs. There is a liver and spleen we have there, right? So there will be at a dull sound. And then in epigastrium region, if it is a air means there, empty stomach means there we can get a tympanic sound, and then dullness means there will be a full stomach because of. So main in major condition, if it is ascites means where what the sound will get, there will be a dull note we can get, right? So and then in the case of any organomegaly also we can get the dull note. So these are the some clinical things regarding the percussion. And then coming into palpation, the abdomen should be soft and non-tender, mainly rigid abdomen because of the hemorrhage and then infection. Soft and non-tender. Non-tender means while palpating the person may feel a discomfort or pain, that is the tenderness, right? So here the person should have a non-tender. Why the abdomen should be soft and non-tender means, so we know abdominal muscle take parting in the inspiration and expiration. So our abdominal muscle like rectus abdominis, transverse abdominis, and then those are the things they are taking accessory muscle of expiration, right? So if the person have a tenderness in the abdominal area, or if the abdomen is rigid means that will restrict your diaphragmatic movement, thereby it will restrict your respiratory effort. That will, the person may have a go into the respiratory distress. That is why rigid abdomen, we rigid abdomen, whether that is there or not, we have to check, and then tenderness of the abdomen also we have to check for. And then coming into last important, major important thing is a pain. So pain is an indicator for some infection or inflammation because of any hemorrhage. Here four types of pain we have: visceral pain, parietal pain, somatic, and then referred pain. Visceral pain mainly it will origin from the area of hollow organs. So the cavity organs like a stomach or your intestine. So there is a major area. Mainly it is because of any organomegaly or organ contraction. Because of that only that visceral pain will arise. So the description how the pain, nature of the pain will be like a burning pain, muscle cramping. So if you are getting muscle cramping means how it will be. So the same like a pain, gnawing and then aching pain will be a common pain in nature. So coming into parietal pain, majorly it will occur because of the peritonitis. Okay, peritoneum, inflammation of the peritoneum. The nature of the pain will be steady pain. There won't be any elevation, there won't be any decrease in pain. It will be in a constant manner. And then achy pain, the person compare with a visceral pain, parietal pain easily the person can localize where they have exactly pain. Okay, the pain and then intensity of the pain will increase while movement. Coming into third pain, that is a somatic pain. It mainly will occur in the case of any infection or inflammation or any disturbance in the peripheral nerve tract. Here also this pain also localized pain, usually it will felt in the deeply. So visceral pain will be in the superficial, but somatic pain will be in a deep in nature. Okay, here also the pain also easily we can localize where the pain is. So referred pain means, so name itself we can see referred pain. So here also any inflammation or any damage in the peripheral nerve tract means that will cause the referred pain. So for example, referred pain means the pathology will be in one area but the pain will feel in the other area. That is called the referred pain. So for example, cholecystitis or inflammation of the gallbladder. There, if the person will have a referred pain at the right shoulder. So that is called the referred pain. The pathology will be in one area, but the pain where the person will feel in the another area. That is called the referred pain. And then finally coming into the next part, final part, that is a reassessment. So as like we told, unstable case means every 5 minutes we have to reassess. Stable cases means every 15 minutes we have to reassess. So what are the things we have to reassess means routine monitoring, pulse, non-invasive blood pressure, ETCO2, SpO2, respiratory rate, ECG. And then if the person have any GA bleeding means we have to close look about the any signs of shock, because they are more tendency to go into the shock For that we have to routinely reassess the person, whether the person get into the shock or if the person impending to the shock, that we have to check for, because here the hemorrhagic shock is most common one. And then we have to reassess like intervention, if any intervention for for pain, if we given any medication, means how the pain intensity after the analgesic. So after 5 or 10 or 15 minutes we have to reassess the patient whether they need another dose of analgesic or any other intervention needed, that we have to check for. And then again, if we given any IV fluid bolus, means there any improvement is there or not. So those are the things we have to reassess. So do your best. Shalom.